Hi there. I'm going to be talking about the Comfort Care tool, which is a nurse's guide to end-of-life care. This is a tool that was created by Dr. Bonnie Freeman, who had named it the CARES tool because it was an acronym for the 5 most common needs at end of life: comfort, airway, restlessness, emotional support, spiritual support, and self-care. It was renamed to Comfort Care tool so that way nurses would know what population of patients they would be using this for. So it'd be patients that are on comfort care, perhaps need comfort care. So that is why we renamed it. Here's what the comfort section of the Comfort Care tool looks like in its entirety. We're going to be breaking it down, going section by section. To start us off, nurses have an ethical responsibility to act as a patient's advocate, so pain control is essential for all dying patients. Something to note, not all dying does not cause pain. It's just whatever disease that the person has. So if somebody has a painful disease, then it's going to be important to provide pain management all the way to the end of their life. And pain at end of life is best managed by around-the-clock scheduling. So doing it every 2 hours or every 4 hours. If you have longer lapse in time, you think that they look comfortable, well then sometimes their pain can get out of control and then you're having to play catch up. And there is no maximum dose of opioids for pain control. Doses are patient specific, especially patients that have multiple myeloma. It's a cancer that eats holes in the bones, like obviously a very painful disease. So they're going to be on higher levels of opiates. And also, too, consider changing the type of opioid if the pain or symptoms remain uncontrolled. For some reason, some opioids, like morphine, is the gold standard for dyspnea, but maybe for some people, Dilaudid would work better. And the medication route will determine when someone's going to have their peak effect. So with oral pills, PO, it takes about 60 minutes or 1 hour. And nurses often worry if the opiate that they're giving, if they're going to cause their patient's death. The patients are dying based on their disease. They're not dying because you're giving them an opiate. There will always be a last dose when caring for a dying patient. And what is the intent? You're not giving them the opiate to end their life. You're giving them the opiate to ensure their peace and their comfort, to help relieve any suffering. So you're focusing on their comfort. And so the patient is dying from the disease process, not the opiate. Patients in renal failure, they may need a different opiate. For example, morphine can be tough on the kidneys, so that's why hydromorphone Dilaudid is processed in the liver is a better choice. Or oftentimes if people are on high doses of opiates, they can start getting these myoclonus, like jerking reactions, and then maybe fentanyl is a better choice. And fentanyl is one that it does start working quickly, and so they can help get rid of those seizure-like tremors. And in those that do have renal failure, they might need smaller doses because it's going to stay in their system a lot longer. So if you continue to keep giving them a higher dose, then they would become sedated. And something that I'm so passionate about is being able to assess pain in a nonverbal patient. They may look comfortable while they're resting there, but if you go to reposition them every 2 hours and you see them furrowing their brow, or they may even moan or groan, then that shows that you need to provide them with pain medication on a more regular schedule. And then that way, when you do go to reposition them, it'll be less of a, maybe a softer moan. It's just so easy to forget to give them pain medication when you've got all these other patients, things are going crazy, and they're just laying there peacefully. But I always pre-medicate before. If I know someone has underlying history of pain, give them a pain dose, and then I wait at least a half hour, if not an hour, to reposition them. And I'll always offer non-pharmacologic pain interventions. It's amazing what even just holding someone's hand can do when they're in pain. There are some guided imagery scripts that you can read. So you could take somebody to the beach, for example. Don't forget about warm packs or cold packs. Massage, a gentle hand massage. Repositioning is great. You can prop people up with pillows. as well as music, just uses as a distraction, and aromatherapy. So don't forget the non-pharm pain interventions. Because the focus of care for the dying patient is comfort, that's why it's called comfort care, comfort first. All unnecessary procedures, tests, and activities should be evaluated. Provide as much time for the patient and family, let them be alone. I even like to put down the hospital railing, so if their loved one's able to crawl in bed with them, they can, just to cuddle. And consider obtaining orders as appropriate for the following. Stop or modify how often you're doing vital signs, because if you're doing a vital sign, usually it's because you're going to do some intervention, right? If somebody's blood pressure is too low, you're going to hold that beta blocker. If someone's blood pressure is high. We're just so used to doing things, but you can just spot check. Because vital signs, it's important to spot check, because that can tell you if someone's uncomfortable or not. If someone's pulse is like 140, they're working pretty hard, and so that would be somebody to give some opiates to. And then also discontinue any oral or just non-essential, like all of their big vitamins. If they're medications that are not needed, things like Keppra, those are always needed. So because you don't want someone to have a seizure, but discontinue all the non-essential ones if they're unable to swallow. And medications like Keppra or other ones that are essential, they can be administered rectally. And also clarify IV orders, because to either discontinue or reduce the rate. If someone is dying, their circulation is slowing down, the fluids will just back up in the limb. So if you put an IV in someone's arm, then the fluid will just start diffusing out into the tissues of the arm. It won't go into the bloodstream, or it'll just leave the bloodstream. And then turn off unnecessary monitors and alarms. Like, for example, the pulse ox machine. You can spot check someone's pulse ox, but you don't need somebody having it beep beep and going into the 80s. And then stop or discontinue lab orders, because it's the same thing. If someone's not going to get a blood transfusion, then why are we checking hemoglobin? And discontinue isolation if it's appropriate. And it's important to note that nurses can provide the following comfort measures without a doctor's order. So you can reposition somebody as needed for comfort. Like if they have a broken hip on the left side, well, then you're not going to be tilting them and put them on the left side. You're going to have it elevated up. You can help them also reposition if they have copious secretions. It can help them settle down. And modify bathing. If someone's not showering anymore, maybe the family would like them to have a bed bath. Instead of doing daily wound care, you can just reinforce the dressings as needed. And because people nearing end of life, they do just naturally get dehydrated. Their mouth can be very dry, so it's important to do frequent oral care using mouth swabs. Or sometimes I would put the swabs in their favorite beverage so that they can taste. Like, for example, my stepmom loved Diet Dr. Pepper, so her mouth swabs had Diet Dr. Pepper. And then using the lip balm too. And only if you see some extra secretions in the mouth, should you suction out of the mouth. Most of it, the sound that you're going to get, the death rattle, that is just from the secretions pulling in the throat. So as the person starts becoming more and more unconscious, they're not swallowing their saliva, so it does start to collect on top of the vocal cords. And so every time they take a breath, it's going through that water. So that's why it can sound so wet, and it can be disturbing, but no deep suctioning. Suctioning can actually cause trauma, so it can cause bleeding. It can actually cause more secretions to want to be released, so it can make the problem worse. And as well as providing temperature comfort measures. It's not uncommon to have a fever at end of life, so there's Tylenol suppositories, but oftentimes you can just help cool the person down by placing a nice cool washcloth on their forehead. I've even done ice packs under their armpits, the axilla. That's another cool way to cool someone down. And also, too, something to explain to the patients and families, or to the families at this point, that mottling and cyanosis, they're just part of the dying process, the circulation slowing down. It's not from being cold. So the next section is going to be airway. Here is the whole airway that's on the Comfort Care tool, but we're going to go through it section by section. All right, so the dying process results in irregular breathing patterns with periods of apnea. Apnea just means without air. So they could just be taking nice, slow, shallow breaths. And then you look over there and then they're not taking a breath. I've seen periods of apnea. It can be 10, 15 seconds, all the way up to 40 seconds. So sometimes people may think that their loved one had already passed and then they take another breath. So I always provide education that those periods of apnea, they can lengthen or get longer, but they tend to be comfortable. It's not something you just want to look at them to see if they're distressed or not. And some signs of if someone's in respiratory distress is accessory muscle use. Like if they're really working hard to breathe, then that's a sign that give them an opioid to help with the vasodilation of those blood vessels so that there's more oxygen that's going to be able to get sucked up in the bloodstream because there's going to be more red blood cells there. Or else if they're restless, agitated, if they look fearful, if their eyes are open wide, or sometimes if their mouth is open, consider obtaining orders for morphine IV if you're in a hospital, or morphine PO. It says don't be afraid to give morphine. Remember, the patient is dying and will stop breathing due to their disease. It's not from receiving morphine. You're just allowing them to be comfortable with the time that they have left. And also, too, if somebody is feeling anxious, because it is common for anxiety to go along with shortness of breath, you can consider anti-anxiety agents. So whether that be lorazepam and or antipsychotics, provide family education as needed. But it's just something that with the breathing, it becomes progressively more irregular, shallow, slowed, and it's just all brainstem activity. It's involuntary. And just emphasize the calming effects of touch and presence, such as talking to the patient, because we know that the last sense to go is hearing. And so continue to talk with the person. And dyspnea, so it's a subjective feeling of breathlessness that can happen at rest or with exertion. Dyspnea can be caused by anxiety, severe pain, urinary retention, constipation, or ascites. So if they have fluid overload and it's pushing up on the diaphragm, then it can cause that shortness of breath. And something to note, the severity of dyspnea is not related to the respiratory rate or oxygen saturation. I've had patients feel short of breath at a 95% oxygen sat, just like the Comfort Care tool has, and they didn't have any labored breathing. It's important to consider non-pharmacologic interventions if someone is dyspneic. Reposition them, having them sit up, like if you're in the hospital at a bedside table, you can kind of have them lean forward and over it, helps expand the lungs in the back. Or increase air movement. So if you're able to open a window or turn on a fan, that's very helpful. And then also within the airway, we're going to talk about secretions. And those secretions often pool in the back of their throat, and it can be loud and gurgly. And it can definitely be disturbing for family because the person's usually minimally responsive by the time this happens, so it doesn't seem to be bothering them. And I like to compare it to snoring. When someone is snoring, they're asleep. It's not bothering them, it's bothering the people around them. And that's how I see the secretions can be. You can consider obtaining orders for glycopyrrolate, scopolamine patch, hyoscine, or atropine. Typically, scopolamine patches that can cause delirium, and it takes a full 24 hours to kick in, and they're expensive, so I don't see scopolamine patches used very much. Glyco and hyoscine are good. They work well, and usually atropine is reserved for somebody who is minimally responsive because it crosses the blood-brain barrier and it's really dehydrating. And so another intervention is reposition them on their side, or else do a semi-prone just to kind of help drain the secretions. And then if needed, use dry mouth swabs or gentle oral suctioning just to kind of get if there's any um, copious secretions in their mouth. And it says reduce fluid intake, so they can just be sucking water on swabs, maybe, because it tends to be patients that are fluid overloaded. So ones with any type of lung disease, heart failure, anyone that is fluid overloaded, then they tend to have more secretions. And the use of supplementary oxygen during the dying process is often ineffective because most people, when they are at end of life, they're breathing through their mouth and the nasal cannula is going in the nose. And so how much oxygen is really getting down into their lungs if they're breathing through their mouth. But it can help. Sometimes I've placed it if it helps the family feel better. It's because it gives them like, okay, he's not suffering, he's getting oxygen, but it's important to review the goals of care established by the patient family for supplemental. If this is somebody who never needed oxygen, then by the time you're giving them opiates, they're getting enough oxygen that way that they wouldn't need supplemental oxygen. And the next symptom we're going to talk about is restlessness. So here you can see the restlessness interventions from the Comfort Care tool, and we'll go through them one by one. So the restlessness that commonly happens at end of life is also called terminal agitation, and it can result from pain, it can result from bladder distension, constipation, infection, or sleep deprivation. And so the most important thing is to keep your patient safe and let the family's needs be supported. It's very hard for them to watch their loved ones. And the best thing to do is use your nursing assessment and figure out what's causing the restlessness. It could be if they're having, uncontrolled pain, maybe they need a trial dose of opiates to see if that helps the behavior. Or assess for bladder distension. Maybe they need to be straight cathed or have an indwelling catheter placed because there are medications that can cause urine retention. And then also assess for stool impaction, constipation. I'm also a hospice nurse, and I have seen a lot of constipation because they tend to be bedridden, so they're not up walking around, they're not eating as much. So constipation is a big problem for people at end of life. And sometimes you need to consider antipsychotics, so Haldol, Thorazine, or there's other medications. We give a lot of Seroquel at bedtime. And for real severe cases of terminal agitation, we do use phenobarbital. But if the patient is actively dying, then you can go ahead and consider the benzodiazepines, so such as Ativan or Versed. If you're in a hospital, it's all based on the setting that you're in and what formulary you have is what medications you have access to. And the key thing is maintain a calm environment. Keep the lights dim. You don't want a lot of stimulation. Talk softly to the person, maintaining use of touch and presence. So important to comfort the patient by saying you are safe, we're with you. I always encourage the family to say I love you and say whatever, just whatever thoughts that if it is something to say I'm sorry or I forgive you, now's the time to do that because they can settle down once any unresolved issues get resolved. And also consider aromatherapy for relaxation. And I jumped ahead of myself here. It's talking about unfinished business may cause restlessness. So discuss with the family possible causes of anxiety. So review with the family the importance of saying goodbye and give permission to stop fighting. Questions, you can ask the family, is there an important anniversary coming up, or is there a loved one that needs to come in from out of town? It's not uncommon for a loved one to come in town and then they die peacefully just a little bit afterwards. So educate the family that the patient, they don't understand what they're doing, that they lack awareness of their behavior, and it is possible for patients to be peacefully confused. And I've seen that numerous times where they just think that they're traveling in an airplane. So I get on the plane with them and ask if they would like a snack or whatever. I've done that. And the next section of the tool is emotional and spiritual support. So here's what it looks like as a whole on the Comfort Care tool. And now we'll go through piece by piece. So providing emotional, spiritual, psychosocial, and cultural support to the patient and family allows us to care for the soul. This is the very foundation of caring for the dying. So it's important to know what are your resources, as well as always work to retain the patient's dignity and feelings of value. Just remember, every family is unique and they're all going to grieve differently. A good communication is essential. Asking the patient, asking the family, what can I do to support you? Um, ensure communication exists with the family in all disciplines. And then, take cues from the family. Don't assume that you know what they're thinking or feeling. I usually always ask follow-up questions just so I can better understand. And a lot of times for the emotional and spiritual support, it's just being a comforting presence, being comfortable with silence. You can use active listening and also find out how much information does the family want to know. Some families want to know every single detail. Other ones want to know just generalized information. And then clarify goals of care. For example, are they want comfort care, or maybe they still want to do some life-sustaining treatment, but they're not going to want to go back to the ICU, for example. Clarify privacy needs. There are some, like if there are some females that may not want a male nurse. Be present with the patient and family, sit in silence. Work with the family to provide favorite activities, smells, sounds, support rituals, and assist with obtaining, right? Maybe you need to get their clergy and their pastor. So those are all important things to be thinking about. And other activities and methods of support to consider is your humanity is needed the most. So just always being available. It's families feel reassured when they know that you're there to answer any questions that they have. Um, and and know that patients and families, they take a risk when they share their emotions, affirm and support their statements. I will be, I thank you for sharing that with me. Um, this must be very difficult. Like if you can put the emotion back in words, then they know that you're listening to them. And the family is an important part of the patient care and becomes the focus as the patient becomes more unresponsive. So I always make sure the families, are they taking breaks? Are they eating dinner themselves? I have brought family members warm blankets or water. You can't take away a loved one's pain, just acknowledge their emotions and be present. I often will ask what's the patient's favorite music. Since most people have cell phones now, you can access podcasts or YouTube videos that have their music. Position the bed so the patient can see out to the window. Since so many of them, they can't get outside, at least turning the bed so that they could look at the clouds. And encourage family. I always encourage them to bring in a patient's favorite pillow or blanket. Once again, dim the lights if you can. And so important is considering a visit from the patient's pet. That is, we all know the benefits of pet therapy, so it's super important for them to see their pet one more time. And the last section that we're going to talk about is self-care. It's the shortest section, but we're going to be updating the tool and adding a lot more to the self-care section. So let's look at it. So as nurses, we must allow ourselves to be human and expect some personal emotional response to not only the death of the patient that we've cared for, also the family. It's really tough. It can be very tough being around grieving family members, especially if the patient is young or if it was sudden. There's just circumstances that are going to make your own grief harder to deal with. And so you can reach out to, if you have access to a palliative care team or supportive care team, oftentimes their chaplain can meet with nurses to debrief and go over just to help process those deep emotions. And as I mentioned on the last slide about debriefing can really help professional grieving and promote emotional health by just recognizing it was a stressful event. You can thank supportive team members, review what went well and maybe what challenges need to be addressed to do something different in the future. You can share bereaved family comments, like if they were so thankful, they're appreciative of the care that their loved one received. Also a chance to address moral distress issues. Nurses are often providing the very care that is causing them issues. If they know, or if they, I should say, the person that, say, is hooked up to a machine, would they really want that if they're suffering horribly? But yet with the families, they're stuck making these decisions. So it can be, nurses get stuck in the middle, and it can be a really tough place to be. As well as there's people that have anxiety around death and obtain support that way. Exploring challenges and the privilege of assisting a fellow human being through the dying process. That's how I see it. I see it's a privilege caring for patients at end of life. They're going to be in that situation anyways, so to be able to make it as comfortable and as peaceful for them as possible. Acknowledge the spiritual impact of witnessing death. Explore how your care made a difference to the grieving family. Reviewing effective communication techniques. What are some resources, support? And then practice self-reflection. Is there something that maybe you would want to do different next time? And mindfulness exercises, whether that be meditation, just focusing on something positive, doing an adult coloring book, that can also help mitigate the effects of burnout. So what we just covered was the comfort care tool. If you would like your own copy, see if it'll come out. If you would like your own copy of the comfort care tool, just go to my website, comfortcareexpert.com, because I'm helping nurses become the comfort care experts so that they can continue to provide compassionate and person-centered care to their dying patients. Thanks so much for listening and watching. Bye.